Well, good morning, everybody. My name is Peter Sever. I'm Professor of Clinical Pharmacology at the National Heart and Lung Institute in Imperial College in London. I am a cardiovascular physician and have a lifelong interest in hypertension and multiple risk factor involvement in cardiovascular disease. And I have particularly been involved in a number of clinical trials of both blood pressure lowering and lipid lowering in the last 10 years. Now today I am going to talk to you about the pathophysiology and treatment of hypertension. Now it's an enormous subject and you will forgive me if in parts I'm going to deal with a number of the topics fairly rapidly, but they are, of course, topics that many of you will be extremely familiar with. So I'm going to try and be all-embracing in the one hand, but that will be at the cost of some lacking of detail in specific areas. All right, well, this was the front cover of the Lancet in 2005, and the clear message there is that across the world high blood pressure is increasing both in the so-called developing world and in the developed world, and we anticipate that by 2025 there will be more than 1.5 billion individuals with high blood pressure. If we look at data from the Global Burden of Disease study, and this was put together more than 20 years ago now. The predictability, as you'll see, for death and disability in 2020 highlighted ischemic heart disease and cerebrovascular disease, and if you combine those, they are very definitely the most common cause of disease in the Western world. Now, having looked at the outcomes and the global profile of diseases, then let's look at the risk factors responsible for those diseases. And you can see from this World Health Report dating back to 2002 that at the left-hand end of this slide, you can see that high blood pressure is by far and away the most common risk factor contributing to mortality, and that this risk is perceived both in the developed regions and in the developing regions. Now, my focus for discussion today is on primary or essential hypertension, which represents the vast bulk of our patients, but let's not just forget those small but important percentage of patients with secondary hypertension, the causes of which are detailed on this slide, at least some of them, but that's really all I'm going to say about secondary hypertension today. Now, this is one of my favorite slides. This is a picture taken many years ago in the Kalahari Desert in sub-Saharan Africa, and what you see on the slide are two Bushmen. Now, the Bushmen have resided in the Kalahari Desert for over 1,000 years. No one really knows where they came from, but they are of great interest in that when they were first studied, they had low blood pressures throughout age, they had no diabetes, they had no heart attacks, and they had no strokes. And this was a comparison made at the time of the blood pressures in the Bushmen, in males and in females, and contrasting with the much more familiar rise in blood pressure with age that you saw here in Londoners, but which is a common profile for blood pressure in age in most so-called developed countries. Now, it's not only the Bushmen. Over the last 50 years or so, there have been a number of epidemiological studies done on remotely living individuals, not only the Kalahari Bushmen, but the Congo Pygmies, the Yanomamo Indians, the Kuna Indians, the Kenyan nomads, those living in isolated atolls in Polynesia, and the New Guinea Highlanders. And these all have low blood pressure. When they move into a more urbanized environment, then the picture changes dramatically, as we will see. Now, looking at that blood pressure in a little more detail, let's start with the Kalahari Bushman here in red. Here is the frequency distribution curve of blood pressure, which you can see is shifted well over to the left, such that you just see a very, very small number of individuals with a blood pressure above a sort of threshold of 140, the conventional threshold above which we call people hypertensive. Now, and you look at the profile of other populations, and here are two civil servants in London and railwaymen in Japan. You can see the whole profile, the whole frequency distribution curve is shifted to the right. And now, of course, we're beginning to see a much higher proportion of the population with high levels of blood pressure. Now, what happens when people migrate? What happens when the Kenyan nomads, for various reasons, migrate across the country into the urban areas of the city? Well, all sorts of things change. There's an enormous change in their diet. Their calorie intake usually goes up. Their carbohydrate, or at least the simple carbohydrates, go up. Their protein intake from animals goes up. Their fat intake goes up. Their salt intake goes up. Potassium goes down, and so on and so forth. And another important factor is that they tend to exercise less. And of course, the great challenge is which of these changes contribute to the rise in blood pressure that we see with migration. Well, I have myself been involved in longitudinal migration studies in the past, and that's a story for another day. But what that study showed, and what many, many other epidemiological studies have shown, is a number of environmental factors that undoubtedly contribute to higher levels of blood pressure in the populations where it's been studied. And I'm going to dwell a little bit on some of these over the next few minutes. Salt intake, hotly debated, but there's now an overwhelming evidence base for its involvement in the blood pressure rise with age and in hypertension. People who are overweight tend to be hypertensive, or at least have higher blood pressures than those who are underweight. Alcohol excess increases blood pressure. A lot of debate about stress, which I'll come back to, and blood pressure. Other dietary factors as yet unknown. And importantly, lack of exercise. Now, over the past, people have focused on individual environmental factors, but of course, for the majority of us, we're exposed to one or two or more of these environmental factors, which almost certainly interact. And they interact not only with each other, but with an underlying inherited predisposition, and the outcome of that interaction is a rise in blood pressure. And the various hemodynamic indices of that are shown here. But at the end of the day, it's the elevation in the blood pressure that's important. How does blood pressure go up as a consequence of these interactions? Well, it involves, in most cases, the activation or deactivation of a number of pathophysiological mechanisms that we all know are involved in blood pressure regulation. This is a slightly different way of looking at it. This was a mosaic, the original version of which was published by the American Irvin Page, probably around 50 years ago, and this has been slightly modified of late with the incorporation of new factors. But what this mosaic tells us is that we've got these various factors around the edge here which can contribute to blood pressure, but they all interrelate. And the importance of that when you come to therapeutics is if you want to lower blood pressure, for example, by interfering with the humoral system, perhaps you want to interfere with the renin-angiotensin system, then yes, that will lower blood pressure. but the body is incredibly resistant to that, and there will be activation of reflex mechanisms in an attempt to combat that lowering of blood pressure. And the point of that particular message is that for most patients with hypertension, you will need 2 or more drugs, the second and third of which are contributing to counteracting the reflex responses to the initial perturbation of the system that comes about with the initial drug. Now then, let's just look at some of those environmental factors, and I haven't got time to go into any of them in great detail. Here's a very early story about prevalence of blood pressure in different countries related to the average salt intake in members of the population. Now, this data has always been very crude because it's difficult to estimate an individual's salt intake. It varies from day to day. If you try and do it with snapshots of urine, then they don't tell you what the average salt intake is over a more prolonged period of time. But this is what they showed, and by and large that's probably right, that the very, very high salt intake countries, particularly Portugal, for example, Moscow, New York, Shanghai, compared with places like the Yanomamo Indians and rural Kenya, where salt intake is very low, they have virtually no hypertension. Hypertension is very common up here. And if you look at the totality of the evidence linking salt and blood pressure, yes, there's epidemiological evidence, there's evidence from genetic studies, there's evidence from studies and experimental models of hypertension, there are salt challenge studies, salt withdrawal studies, clinical trials, placebo-controlled, and so on and so forth. And it really is an enormous evidence base, and it's really hard to get away from the fact that if you don't have salt in your diet, then you don't get high blood pressure, and if you do have salt in your diet, you almost certainly will have an elevated blood pressure that goes up with age, and in a proportion of people, they will become hypertensive. What about weight, or BMI, and blood pressure? A huge wealth of observational data and trial data on what happens when you lose weight, when you gain weight. That's always associated in populations with changes in blood pressure. The strength of the relationship is seen both in men and in women. It is a pretty crude relationship because, as we know, there are all these other environmental factors involved. And if you've got the right genes and you are overweight, then your blood pressure will go up. If you have not got the right genes and you increase your weight, then your blood pressure might not go up as much. So there is a huge variation in the relationship, but at a population level it is there and it is hugely important. And of course what we do know about excessive weight is of course the increasing risk of the insulin resistance syndrome, central obesity, resistance to insulin-stimulated glucose uptake, glucose intolerance. This is associated with hyperinsulinemia, metabolic abnormalities, and a rise in blood pressure. Now, what about alcohol? Well, I could show you a lot of observational data. This is a very, very old slide from some population-based studies in North America, looking at their white population, their black population, and what they described then as their yellow population. I think that would not be an acceptable term today, but this, I suspect, reflected the Chinese immigrant population and probably Japanese immigrant population in the US. But the point of the slide is that in both men and in women, the higher the alcohol intake, in terms of the number of drinks per day, the higher the levels of blood pressure. And that is broadly the case with much more recent studies. Alcohol is a very, very important, or excess alcohol, a very important cause of high blood pressure. Now, what about stress and blood pressure? If you ask the average man in the street what causes high blood pressure, he or she will almost certainly include stress as one of the top 2 or 3 causes that he or she is aware of. But it's much harder to provide good, sound evidence for the association of stress and blood pressure. This is seen in a number of areas. There's work stress. I'm going to show you a couple of slides from Tom Pickering's observations in the United States. We know that certain occupations where stress levels are perceived to be very high are associated with higher levels of blood pressure, and that's certainly the case of air traffic controllers. Conversely, in a group of closed order nuns in northern Italy, they're excluded from the real world, and they have very low blood pressures that do not rise with duration or increasing age. And we've shown in our own studies from migration that the urbanization of tribespeople is associated with a very, very high stress factor, which we think contributes, along with changes in dietary sodium, to blood pressure elevation. Now, we know that short-term stresses are instrumental in causing minute-to-minute changes in blood pressure. This is a very old slide from the famous George Pickering back in the 1950s. Is one of the earliest intra-arterial 24-hour blood pressure recordings. And you can see these marked variations in blood pressure during the day and during the night. And here, a hospital visit associated with peaks in blood pressure. So there's never really been a doubt about stress or acute stress and blood pressure. It's the chronicity of blood pressure elevation that's been the challenge. Now, here is some of that data on work stress or job strain from Pickering's group in New York, published a number of years ago. And this is quite interesting. They categorized people in the workplace as being under low or high psychological job demand. I think that concept is really quite simple. But then it is a little bit more complicated when they took the workforce and divided them into those that had high and low job decision latitude. And what that means is that if you are a worker and you are continually told what to do by your manager, then you don't have any decision latitude in your job. On the other hand, if you're a senior manager, then you do have a lot of decision latitude. And it is the people that have a high job demand, but a low ability to be able to cope with that demand, that have the highest levels of blood pressure in this relatively small study. But I think really quite an important study, that you imagine yourself in the workforce and you're being told by the boss what to do, and you've actually no control over that. Then you're in a much worse position, a much more stressful position than if you're the senior manager and you are more in control of things. And this is another slide from their study looking at the effects of job strain on ambulatory blood pressure at work. And it does appear that those under high strain, particularly in the older age groups, have a more demonstrable effect on elevating blood pressure. What about exercise? Again, there's a wealth of data showing that exercise training is very good for lowering your pressure. This was an interesting study in patients who had recovered from a stroke and went through an exercise training schedule. And here on the left-hand side in the exercise group, you can see their pre-treatment blood pressures on exercise, and in the black circles, their post-exercise treatment blood pressures, again during exercise. And they really highly demonstrable and highly significant fall in blood pressure as a consequence of exercise training. So let's back to our little schematic of environmental factors interacting with an underlying genetic predisposition. And you'll see in parentheses here I've got all intrauterine factors, and I'll have a brief comment about that in a minute. But just for the moment, let's turn to genetics. Now, here's an early study looking at twins, and this was really quite a good way of getting a handle on the extent to which your blood pressure and my blood pressure is dictated by our genes. And here we're looking at the correlation coefficient for systolic pressure in red, diastolic pressure in black, in monozygotic twins, in the broad ones here, and dizygotic twins in the narrow lines here. Now, of course, these monozygotic twins are much more genetically identical than the dizygotic twins, who are similar but by no means genetically identical with each other. And when you extrapolate the correlation coefficients of blood pressure between the twins, both monozygotic and dizygotic twins, using a not too complex mathematical maneuver, you can come up with an estimate of the extent to which inheritance contributes to those blood pressure levels. And from the twin studies, it comes out at around 60%, or perhaps approximately 2/3. And that is the sort of figure that's seen in other estimates of the hereditability of blood pressure. And that, I think, is probably a fairly accurate assessment. Now, what we know about inheritance is that, and hypertension, it is highly probable that the kidney is instrumental in a lot of these hypertensive cases. We know that in the genetic models of hypertension in animals that the kidney is involved. In the rare genetic cases of hypertension in man, the monogenetic cases, which I'll show you in a moment, the kidney is involved in virtually all of them. And in post-transplant hypertension in humans, there is clear evidence that if you inherit a transplant from a hypertensive individual, then as a recipient, you're much more likely to develop high blood pressure than if you inherit a kidney from a normotensive individual. So all these studies tend to point the finger at the kidney. Now, just for a moment, let's follow that story on monogenic hypertension, and there are a number of cases of monogenic hypertension, apparent mineralocorticoid excess, which appears to be associated with deficiencies of 11-beta hydroxysteroid dehydrogenase. We have inherited abnormalities of the epithelial sodium channel. There are abnormalities of the Wnt kinases, all of which in the tubular cells of the kidney will result in a monogenic form of hypertension. So again, more evidence supporting the fact that there's something in the kidney that is responsible for hypertension causation. Turning now just for a comment on genomic factors in hypertension, there have now been a large number of genome-wide association studies in huge numbers of individuals searching for the blood pressure gene with almost complete failure. Although in these GWAS studies they've identified a number of loci that appear to be associated with higher levels of blood pressure. In each and every case, that particular isolated abnormality rarely accounts for more than about 1 millimeter of blood pressure difference between one gene abnormality and another. I suspect with an accumulation of a number of these gene defects, then that will mount up and contribute to higher levels of blood pressure. But this whole scenario has been, I think, much more disappointing than many of the geneticists had hoped. But it is, of course, indicative that we're dealing with a polygenic phenomenon and a multifactorial condition in which it is highly unlikely that we're likely to find single gene defects that are important. Just a word on what we now know as being the Barker hypothesis. Barker was an epidemiologist in Southampton in the UK, and he was the first to report an extraordinary association between babies that were born underweight and higher levels of blood pressure in later life. Now, this is an extraordinary, and I must say I thought biologically implausible association, but it's been repeated many, many times. And there's something about the intrauterine nutrition of the fetus that is associated with higher levels of blood pressure in later life if it is impaired. And it's not only higher levels of blood pressure, it's also the development of diabetes and the risk of stroke and heart disease and so on. And the most plausible explanation is it's something to do with the programming of the development of the vascular system and the kidney and so on, which if impaired at an early stage may be the background for the development of high levels of blood pressure in later life. Now let's move on to causes and consequences of hypertension. And let's look for a moment at the blood vessels. On the top side of the half of the slide here in blue, we have the small arteries and arterioles. These are found in younger hypertensive patients. There is remodeling, both hypertrophic and eutrophic remodeling of these small blood vessels. And this leads to both systolic and diastolic hypertension. However, as you get older, as shown in the bottom panels of the slide, it is your large arteries, and here are the carotid arteries, normal on the left or in younger people, and as you get older, then the walls thicken, they become more rigid, there is rupture of the elastin, collagen deposition, there's calcification, and they become much more rigid. And it is this rigidity leading to a more resistant and rigid circulation that's responsible for the rising systolic blood pressure with age. And this is taken from one of the Framingham studies, not the Framingham studies, from an observational study published many, many years ago. And you can see here the familiar rise in blood pressure with age for men and women, but as you pass the late 50s, there begins to be a decline in diastolic pressure and a widening of pulse pressure, an increase in pulse wave velocity, and it is this combined effect of a high systolic and a low diastolic that confers very high cardiovascular risk. Another interesting observation, really from a long time ago, this is a result of a discussion and debate between Björn Falkhoff, the physiologist from Sweden, Tony Lever, a hypertension specialist from the UK, pointing out that whatever it is that initiates your blood pressure rise and your blood pressure begins to go up, as a consequence of that, you will then get structural change in your blood vessels, and that in turn will feed back and accelerate the blood pressure rise. So you've got a sort of vicious circle here where the blood vessel structure is actually contributing to the hypertension that's probably initiated it in the first place. And there may be various other factors involved. Now, what does this all cause? Well, what we know from, again, the observational studies looking at stroke and ischemic heart disease mortality against blood pressure. The higher your blood pressure, the greater your risk, both of stroke deaths and ischemic heart disease deaths. It's interesting that as you get older, that risk increases dramatically, independent of blood pressure. So between the ages of 50 and 80, there's a huge increase in risk of stroke as a consequence of your age, independent of your blood pressure, but blood pressure itself obviously contributes to that increasing risk. Myocardial infarction, heart failure, dissecting aneurysms, renal vascular disease and peripheral vascular disease, all consequences of hypertension. Now, hypertension is one of the risk factors, and there are others, but that is a story for another day. In the brain, I guess the most important, that is almost exclusively blood pressure related, are these small lacunar strokes due to interruption of the small perforating arteries and arterioles. But all these other pathologies, cerebral hemorrhage, cerebral thrombosis, an increase in embolism, particularly from the carotid, TIAs and so on, hypertensive consequence or consequences of hypertension in the brain, and of course the very severe malignant hypertension can cause multiple small vessel disease and encephalopathy, which fortunately we see much less commonly these days. Hypertension is probably the most important contributor to the ultimate development of heart failure. Again, there will be other contributing factors such as ischemic heart disease and atherosclerosis and so on. But here we see normotensives and hypertensives with a marked increase at all ages of heart failure in the hypertensive individuals. Turning to the kidney, again, in both ethnic groups in North America, the higher the level of blood pressure, seen in the Mr. Fit Screenies as a massive observational study reported many, many years ago, the greater the risk of renal failure. Now, one other important observation we made in collaboration with the specialist stroke physician Peter Rothwell some years ago and published in the Lancet, and based on studies not only from our trial, the Anglo-Scandinavian Cardiac Outcomes trial, but from many, many other trials, and is that it is the variation in blood pressure week by week, month by month, year by year, and not the average blood pressure that is the most important determinant of stroke risk and coronary risk. Now here we've got data from over 1 million blood pressures recorded in the ASCOT trial, and what has been reproduced on this slide is not blood pressure here, but the blood pressure variability from visit to visit. And this is represented by the standard deviation or the variation independent of the mean. And what you see as increasing blood pressure variability occurs, and these are deciles because we had so much data, so is there a progressive increase in the risk of stroke and of coronary disease. So the bottom line here is blood pressure variability contributes to the high risk of stroke and coronary disease. And this is long-term visit-to-visit variability. Now, other forms of blood pressure variability do confer increased risk, but they are not as dramatic as long-term visit-to-visit variability. And this has been shown, this in our own study was from ASCOT, but it's been confirmed in a number of other trials and in a number of other observational studies. And there's also a wealth of data from Japan dating back to the 1990s showing that blood pressure variability is extremely important in determining stroke and heart disease risk. Now we should say something about risk factors in combination. Now this is a cartoon taken from the hypertension clinic, the diabetes clinic, and the lipid clinic. Now in my hypertension clinic, I would think the majority, perhaps 2/3 of them, will have abnormal lipids. About 1 in 6 will have diabetes, and almost half of them are overweight. Now, if I go next door into the diabetes clinic, 2/3 of their patients will have high blood pressure, 2/3 of them will have abnormal lipids, and they're nearly all overweight. And likewise, if you go into the lipid clinic down the road, they've all got other risk factors. Now, of course, if we go back 10, 15, 20 years, the blood pressure doctors treated the blood pressure, the diabetes doctors treated the sugar, and the lipid doctors treated the lipids. And no one really concerned themselves with a more holistic way of patient management. Because our hypertensives are dying of atherosclerosis, and you've got to treat all their risk factors together and not just the single one that perhaps they've been referred with. We know from some very, very old data from Framingham that if you put the risk factors together, then you markedly increase the risk. You don't just add the risk. There's almost a multiplication of risk if you combine two or more risk factors together. So again, important to intervene. Now, what do the trials of blood pressure show us? This is a recent meta-analysis of the intervention trials of blood pressure lowering, and it's a summary of the benefits per 10 millimeter reduction in systolic pressure. Now that's the kind of average reduction in blood pressure. If you take 100 patients in your clinic and in my clinic and you treat them all, and you bring them all back and put all the numbers, that's about the reduction in blood pressure that you'll see. It's what you see in general practice, and it's what you see in what you saw in a lot of the early placebo-controlled trials. Now, if you achieve that 10 millimeter reduction in systolic pressure, you will reduce major cardiovascular events by 20%. You'll reduce coronary heart disease events by 17%. You'll reduce stroke by 27%. And you'll reduce heart failure by 28%. Small effect, non-significant on renal failure, and you'll have a significant effect on all-cause mortality. So it's a hugely important benefit from lowering systolic pressure by 10 millimeters of mercury. Now, of course, if you've got patients that turn up with systolics of 170, 180, 190, and you control their blood pressure to less than 140, you can multiply up this benefit enormously. And that benefit occurs very, very rapidly after the onset of treatment. These are data from the blood pressure lowering treatment trialist collaboration. It's a meta-regression of blood pressure lowering trials looking at the percent reduction against the difference in systolic blood pressure. We've got stroke here, coronary heart disease in the top right, all-cause mortality bottom right, and heart failure left. And as you can see, here's the reduction in systolic blood pressure along the bottom of the slides, and you can see the greater the reduction in systolic blood pressure, the greater the benefit in terms of stroke, coronary heart disease, heart failure, and all-cause mortality. And the data are really quite dramatic for stroke. They're a little bit less dramatic for coronary heart disease, and that's what we would expect from the epidemiology. Blood pressure is a little more important than cholesterol, let's say, for stroke, and the situation is reversed for coronary heart disease. Now, there's a little bit of caution about lowering blood pressure dramatically in patients with established coronary heart disease. Now, there are 2 or 3 studies now that suggest if you take patients, hypertensive patients with established coronary heart disease, and this is data from the INVEST trial, you can see a U-shaped curve with the diastolic pressures down here on the left-hand side of 60 and less, showing an increase in the incidence of myocardial infarction or stroke. And it's particularly myocardial infarction that becomes a risk when diastolic pressure falls below around 65 millimeters of mercury. And that, of course, is in patients with established coronary heart disease. You do not see the J-shaped curve in patients who do not have coronary heart disease. Turning now very briefly and coming towards the end of my presentation to treatment guidelines. Now, there's always a problem with guidelines because there are no 2 guidelines that are the same. And this, unfortunately, in many countries gives people an excuse to ignore them all. The problem that I see with guidelines is that they're far too complicated and they're not very consistent, and we need to simplify them and we need to make them consistent. If we look at targets for blood pressure, then if you take the European guidelines and the United Kingdom NICE guidelines, they very clearly advocate a target of less than 140/90, unless you have very high-risk patients in whom a lower target of less than 130/80 is recommended. Now, the new American guidelines are largely influenced by the SPRINT trial, They've not only redefined hypertension, but they've set a lower target for treatment of less than 130/80. Now, why are these two highly discrepant recommendations based on an analysis of the same studies? Well, I think what we believe in Europe, and particularly in the United Kingdom, is that the blood pressure levels or the blood pressure measurements in the SPRINT trial were taken on patients who were left hooked up to a blood pressure monitor in a quiet room without an attending doctor or nurse. They were left quietly to their own devices, and those are conditions under which we know blood pressure will fall. I do that in my own clinic. I've got someone with a slightly elevated blood pressure. I put them in a quiet room, hook them up to the ambulatory monitor, close the door, and leave them there for 10 minutes. And of course their blood pressure comes down. And on average, it is about 10 millimeters or more lower than the casual pressures that we record in the clinic by the nurse after sitting quietly for 3 times, but when the nurse or the doctor's in the room. So, because the real world is your clinic and your surgery, where you take 2 or 3 measurements of blood pressure and you make a decision on it. And that's the 140/90. If you want to put patients in a room and leave them there for 20 minutes and so on and use the 130/80, well, okay, fine. But these are not comparable. They are based on different circumstances under which the blood pressure has been taken. What about choices of drugs? Well, the Americans have always advocated initial monotherapy with a thiazide. I do not know why. And then they say, well, you can use any of the other drugs, but not a beta blocker. The European guidelines, the new European guidelines, recommend an algorithm where you can have any of the drugs, but not a beta blocker. But the UK guidelines and the American Society of Hypertension guidelines recommend an algorithm based on age and ethnicity. An example of that is shown on this slide. This is from National Institute of Health in the United Kingdom and the British Hypertension Society. And we have adopted what used to be the ABCD rule, which is really now the ACD rule, and that the initial choice of a drug is based on age and ethnicity. If you are under the age of 55, you get an A drug, which is an ACE inhibitor or an angiotensin blocker. If you're over the age of 55, you get a C drug. Now, it used to be C or D, but the C drug, which is a calcium channel blocker. If you don't control blood pressure, you combine them. And if you don't control blood pressure with a combination, then you have an A plus C plus D. Now, this discrimination on age is all due to the declining activity of the renin system with age. In the elderly, low renin, patients respond better to a calcium channel blocker. In younger patients with an activated renin system, they respond better to an A drug. So that's the simple algorithm for mild and moderate hypertension. And then you go on to additional drugs, particularly spironolactone in more treatment-resistant patients. Many guidelines now recommend starting with combination therapy, particularly in patients with moderate to severe hypertension, and there's good evidence from trials that that's not associated with an increased incidence of side effects. So that's a very important observation, and of course you'll get patients to go quicker by doing that. And finally, multiple risk factor intervention in hypertension is extremely important. If you take patients in the statin trials, here in yellow on the bottom are the risk reductions, but of course you're left with a proportion of patients in blue there whose events are not avoided. If you take patients in the blood pressure trials, in yellow here you've got the risk of the primary event reduced, but in blue you've got the patients who are not benefiting. So clearly more risk factors have got to be addressed. And this is what happens if you combine blood pressure and lipid lowering from meta-analyses of the placebo-controlled trials with blood pressure lowering of around 15/10 you reduce coronary disease by 30% and stroke by 45%. If you reduce lipids by 1 millimole per liter or 40 milligrams per deciliter, you'll get a reduction of 25 to 35% in coronary disease and a 15 to 20% reduction in stroke. You combine these two and you get a 50 to 55% reduction in event rates. So a very, very important impact. And of course, if you add in the benefits of smoking cessation, you'll achieve additional benefits. Now I'm going to skip, in the interest of time, the next 3 slides and bring my presentation to a conclusion. The pathophysiology of hypertension is complex. It involves multiple environmental factors interacting with a largely unknown genetic predisposition. We know what the consequences of hypertension are, but we also know they're potentially reversible and preventable. Blood pressure variability, as well as average systolic blood pressure, is important to predicting which patients are going to have cardiovascular events. Lifestyle intervention is essential. It usually requires additional drug treatment. We're not, as physicians, very good at getting our patients to change their lifestyle, but those that will respond to weight reduction, changing salt intake, exercising, and so on, can have beneficial effects that are as good as a drug. And the patients need to be reminded of that, because that's an additional incentive to comply. We have guidelines that provide thresholds and targets. There's too much debate about which guidelines to follow. I think we would still maintain the 140/90 threshold and perhaps drop it to 130/80 for high-risk patients. And finally, multiple risk factor intervention should be the rule for all patients. So with that, I thank you very much for your attention today, and I would be delighted to answer any questions. My first question is, how long the combination of aspirin and clopidogrel should be administered post-myocardial infarction? Well, thank you for that question. It's not really related to hypertension, and there's been, I think, a lot of debate about that for cost reasons in the UK. Originally, the clopidogrel was only given for 6 months or a year. But I think now the costs have gone down. There is increasing evidence that the benefits of combined therapy will continue. But that's something that you should get on your own national guidelines, and it will be influenced by the added degree of protection against the additional cost. Next question is, which, I think composition means composition is suitable for elderly hypertensive. That's a very interesting question. In our algorithm, we tend to start with a calcium channel blocker. Amlodipine is the longest acting calcium channel blocker. Like all the other drugs now, they are generic, so cost doesn't really come into it. And in terms of combination, we advocate combining it usually with an angiotensin receptor blocker. People will say the strongest evidence base is with an ACE inhibitor. That may be true, but cough is an increasing problem with age. 20% of patients on an ACE inhibitor will get an irritating dry throat. It often gets missed by primary care doctors, and I think you might as well avoid it by giving them an ARB. So we give them the C drug plus the A drug as a combination. Next, in resistant hypertension, what about using beta blockers and diuretics? Well, what our original guideline said was that after your A plus C plus D drug, you had a number of options as fourth line. You had a beta blocker, you had an alpha blocker, and you had more diuretic. Now in the UK, a couple of years ago, we did a series of trials called the Pathway trial, and we looked at all the different add-on drugs for resistant hypertension and compared with a beta blocker and an alpha blocker. The drug spironolactone was by far and away the most effective as a fourth-line add-on drug. And that is confirmed by the fact that many of these patients are salt-retaining, and additional diuretics, such as spironolactone, are very good. If you run into problems with spironolactone, then amiloride, probably at higher doses than we've hitherto used, like 10 to 20 milligrams, is extremely good. The next question is, how frequently should we measure blood pressure? Well, that's a difficult one, isn't it? I mean, if you've got a patient with established hypertension, you've got him or her on treatment, and their blood pressure is controlled, then we would see them probably every 3 months. If your hypertensive on treatment is not controlled, I think they should be reviewed every 4 to 6 weeks, depending on resources and so on. But bearing in mind that most hypertension clinics can be managed by nurses, you know, as long as the nurses have got their prescribed algorithms, they're very, very good at following them and managing patients. And that almost certainly extends to healthcare workers in general. But I think if you're still manipulating the blood pressure treatment in order to get to goal, then I think sort of 6 weeks is reasonable. I think once they're stable, 3 to 4 months is fine. Let's move on. What is the first-line drug for isolated diastolic hypertension? That's a great question. I never treat isolated diastolic hypertension. I get into all sorts of arguments about this. You really only see isolated diastolic hypertension in young people. You rarely see it in old people. It's fair to say that if you've got diastolic hypertension, you're more likely to develop systolic and diastolic hypertension in later life. The problem is that if you're 25 or 30 with a diastolic pressure of 100 and your systolic is less than 140, your risk associated with that is very, very, very small. And it will not reach the threshold, the 10% 10-year cardiovascular risk threshold that the Americans and the British now use as a way of treating patients in whom you're not sure whether to start treatment or not. So, although it's a marker which flags up what might happen in the future, I can honestly say in the last 10 years or more, I have never treated a patient with isolated diastolic hypertension. If the patient doesn't respond to a combination of a calcium channel blocker and an ACE inhibitor, then the diuretic should be added. And all the evidence is that chlorthalidone or indapamide are better diuretics than hydrochlorothiazide. If you actually look at all the trials, hydrochlorothiazide in lowish doses has never been shown to be a good drug for hypertension. It simply doesn't have the outcome data, whereas chlorthalidone does and indapamide does. Now, I'm aware that chlorthalidone is actually not available in a number of countries. It's a very old drug, but it is a better diuretic. What's the first-line drug for isolated systolic hypertension? Isolated systolic hypertension is more difficult to treat. There are no trials really apart from HYVET, which used an ACE inhibitor and a calcium channel blocker, but I think in line with just our age treatment recommendations that you should start with a long-acting calcium channel blocker. The next question is, how safe is benedipine in the elderly? I'm afraid I'm unable to answer that question. I'm assuming it's a calcium channel blocker. We don't have it in this country. My views on calcium channel blockers are the longer the action of the drug, the better. For those of you who are as old as I am, you will remember short-acting nifedipine, which has dramatic effects on blood pressure and is a very good way of stimulating acute angina due to the very rapid falls in pressure, compromising the coronary circulation in patients with coronary artery disease. So long-acting calcium channel blocker is safe. Which one is better, a mercury manometer or a digital BP instrument? Gosh, we had lots of discussion about that a few years ago. In Europe, of course, you're not allowed to use any mercury-containing instruments anymore. I think this is based on the potential environmental hazards of mercury. It gets into the water system, it gets into the seawater. I seem to remember reports of yellowfin tumor being caught and having very high levels of mercury in the Far East. But we no longer have mercury manometers. They probably were the most accurate. But the difficulty, of course, with mercury manometers is it's dependent on the observer's ability to detect the Korotkov sounds. And when you actually did tests, doctors were really very poor at picking up the emergence of the first Korotkov sound and the disappearance of the fifth Korotkov sound. So we're really all on to digital monitors of one form or another. I think the message should be, at the moment, that we should use cuff measurements and not wrist measurements, because wrist blood pressure measurement is very, very sensitive to the position of the wrist. If the wrist is high, the blood pressure will fall. If the wrist is low, the blood pressure will go up. So it adds another complication to a very imprecise measurement anyway. Which calcium channel blocker is best? Well, I think I've alluded to that. I believe it's amlodipine. It's the longest acting, and it's the one with the best trial evidence. We've seen many patients with 12.5 milligrams of chlorthalidone causing hyponatremia. Well, I suppose if you've got a very large practice, yes, in the elderly you will see hyponatremia with chlorthalidone. You'll see it with all the diuretics, but there is indeed a suggestion that chlorthalidone is, perhaps it's because it's more potent than the other diuretics, and it certainly acts in a slightly different way. So, I mean, as with anybody, particularly elderly patients, I mean, they should have regular electrolyte checks and creatinine checks. How safe is an ACE inhibitor or an ARB in hypertension with chronic kidney disease? I think there's unreasonable alarm here. There's very good evidence, I think, that ACE inhibitors and ARBs, or inhibitors of the renin system, do have a protective effect and will slow the decline in renal function in patients with chronic kidney disease. You've just got to be careful that the patients don't have underlying renal artery disease, and that should be, I mean, if you've got a patient with impaired renal function, then at least some simple tests need to be done to make sure the patient hasn't got renal artery stenosis, because then the ARB and the ACE can cause quite dramatic falls in renal function. What's the advantage of azilsartan over telmisartan? Well, that's very interesting. I've just co-authored a paper on that, which is coming out in the Journal of Renal Angiotensin System. Azilsartan is a very interesting drug. I mean, many years ago, I was convinced that there really weren't much in the way of difference between different sartans, but azilsartan does appear to be more potent, more effective. It lowers blood pressure more, and by several millimeters of mercury. There are a couple of papers already in print in quite well conducted studies with these two drugs in comparison, both with and without diuretics. And in both cases, the azelsartan seems to come out rather more effective without any increase in side effects. Next question is, should first-time high BP and young be treated immediately or observation? Well, I don't think you should ever treat an isolated high blood pressure. I mean, you take a 20-year-old who has a nosebleed and goes to their accident and emergency department, and his systolic pressure is 190. Now, should you rush in and treat his blood pressure? No, certainly not. It's not the blood pressure causing the nosebleed. It's the terror associated with the nosebleed causing the high blood pressure. So you should always repeat it. And isolated high readings do not confer any significant risk. And particularly in young people, you don't want to label them as being hypertensive and starting on a lifetime of treatment when, if you've taken, 2 or 3 months with repeated measurements of blood pressure to get an idea of what their usual blood pressure was, then you'd be pretty sure that you were dealing either with someone who was normotensive or someone who had persistently elevated blood pressure. And these are the people that we find it's very useful to encourage them to buy a home blood pressure machine, measure it 2 or 3 times a week, and bring it back to you in the clinic or the surgery, and you can compare their readings with your readings, and then you can decide when to treat. So you should never really treat an isolated single value. Well, very nice comment from one of the listeners thanking me for an interesting discussion of hypertension. And another question, and he's also asked, what's the immediate management of malignant hypertension? Well, if you've got another hour, I suppose we could go into this. I think the important message here is to distinguish between what is urgent and what is an emergency. And people that just turn up with a very high level of blood pressure, even if it's 250 over 150, you shouldn't start with blunderbuss treatment. If you give people who don't have heart failure, don't have retinal bleeds, just have an isolated, very high blood pressure with which they present, then you give them amlodipine, and you see what happens over the next couple of hours or so, and then you add in probably an ACE inhibitor or an ARB. If it's emergency, then you should bring them in to a high dependency observation unit, and at the moment I think intravenous nitrates are the treatment of choice, but with very careful monitoring of the blood pressure and adjustment of the infusion according to the blood pressure level. The hypertensive emergencies with acute left ventricular failure, very, very difficult problem and hazardous problem. You've clearly got to treat the acute left ventricular failure, and I think nitrates are probably my first choice there. Next question is, all young hypertensives need to be ruled for secondary hypertension? Well, the correct answer is yes. If you have a 25-year-old hypertensive and sisters and brothers are hypertensive and mother and father's hypertensive, then almost certainly they're probably going to have a very strong genetic component, and their blood pressure has risen as they've got older rather more quickly than other people. But I think everybody, you need to test the urine. We would do an ultrasound of the kidney, and you get an idea as to, from the Doppler studies, as to whether or not there's any obstruction to the renal arteries. We would do a renin and an aldosterone, and combined with the electrolytes, you'll be able to rule out most of them. Anything suggestive of attacks of blood pressure, then you need some catecholamines in the urine. I think you've got to be aware that secondary hypertension is high on the list. Sleep apnea is another important one. but of course you often don't find it. Does olmesartan increase the conversion of prediabetes to diabetes? I'm not sure I know the answer to that question. By and large, sartans should not increase the conversion of prediabetes to diabetes. I don't know whether there's anything specific about olmesartan. It's not a sartan that I particularly use in the UK, but I would have to defer to PubMed to be able to give you a definitive answer on that. How many times in people with high blood pressure who remain asymptomatic should we start? Again, it depends on the level of the blood pressure. You know, if the blood pressure is less than 160 systolic, we would measure it perhaps on 2 or 3 occasions, send them off for a 24-hour ambulatory blood pressure reading, and then we would treat on the basis of the findings. If someone turns up with a blood pressure of 190 systolic, then we'd measure it 2 or 3 times over a matter of days and then get treatment initiated. And someone whose blood pressure is around 140 and they're worried about their blood pressure, then you put them on lifestyle measures and you can follow them up for 6 months or even longer. Sometimes my decision to treat in borderline hypertension is based on an echocardiogram. Now I know that's an expensive test to do, but if you're not certain whether someone's hypertensive or not, if you're not certain whether you want to put them on treatment, which in most cases is going to be for life, if you can exclude a high proportion of them because they've got a completely normal echocardiogram, then I think that's a very useful observation. Amlodipine has a very long half-life, but some people here administer it BD. Well, there's no reason to administer it BD. Its duration of action is at least 48 hours and probably longer, and so there's no indication to give it twice a day. That, I think, is the last question that I have on the list. If that is the case, then I'd like to thank you all for listening. I'd like to thank you all for some very interesting questions, the odd one of which, as always, I could not answer. But there'll never be a day when I get a question, all the questions that I can answer. But thank you again for your listening, and I wish you all well. Goodbye.